we're going to talk about my favorite subject, scleroderma. And I do have the chat if somewhere there. If anybody has any questions, they can put it in the chat and I can certainly answer it. So maybe, why doesn't it move? There we go. Okay, so we're going to start out just talking in general about scleroderma. And there are two main groups of systemic sclerosis, limited cutaneous and diffuse cutaneous. Now, some of you probably trained at medical schools that they still try to talk about CREST syndrome. And we've, as a community, have tried to get away from that designation a long time, and we really refer to this as limited cutaneous disease and diffuse cutaneous, because some of the other features can be in both groups, and certainly the CREST is not unique to limited scleroderma. But the classic limited scleroderma is someone with Raynaud's for many years, don't have a lot of systemic symptoms, have minimal joint complaints, they have lots of puffiness in their fingers. They rarely will have progression from limited to more diffuse disease, and the anti-centromere antibody is the classic antibody. The diffuse cutaneous group is a much more aggressive type of disease. Often the Raynaud's is even delayed. They have lots of constitutional symptoms, lots of joint complaints, carpal tunnel, tendon friction rubs, not just swollen fingers, but whole swollen hands, and actually often swollen legs. And often they actually come to cardiologists or endocrinologists or some other specialty because of the swelling in their legs. And the two antibodies that are most common in this form are the anti-SCL70 or topoisomerase, and then the anti-RNA polymerase III. And we'll talk about these more in a minute. Why is this not working now? There we go. So the natural history of these two forms is that the diffuse disease is much more acute in onset, and the major organ systems often occur in the first 5 years of disease, particularly renal crisis and heart failure, but also the contractures and the most rapid onset of skin thickening. So this on this side is skin thickening, and this is disease duration. So you can see most of the damage is done in the first 5 years of the disease. Pulmonary fibrosis happens early, but they don't necessarily have symptoms until later. And then sometimes the skin, even without any treatment, has some improvement later on. Whereas the limited cutaneous, they don't have a lot of symptoms early on, and then later they can have pulmonary arterial hypertension and malabsorption. This is from a study that I did when I was at the University of Pittsburgh, and it was a large single-site natural history study of scleroderma. And we showed that although renal crisis, this is the red bars, was the major cause of death early in the 1970s and 80s and even into the 90s. But when we got treatment with ACE inhibitors, that now has become less than 5% of all causes of death in scleroderma. And the main two causes of death are pulmonary fibrosis and pulmonary arterial hypertension. And so I think a lot of sclerodermatologists have become sort of quasi-pulmonologists because we see so much pulmonary disease in our patients. So the autoantibodies have been very important for trying to understand the symptoms and the natural history of the disease. The patients, the antibodies themselves are not pathologic. We really have not found a lot of evidence that these antibodies cause the disease or any of the manifestations, but they're excellent markers for the manifestations. So the three main autoantibodies in the United States are the anti-centromere antibody, the anti-topoisomerase antibody, and the anti-RNA polymerase III antibody. U1-RNP, which is the classic mixed connective tissue disease, can certainly be seen in only scleroderma patients, but it can be seen in lupus or myositis, as well as the classic MCTD. And these other antibodies, anti-THTO, U3-RNP or fibrillary, and PMSCL, are all nucleolar pattern ANAs. And that's really important because we really don't have great assays for the U3 and the THTO antibody. And so sometimes the only way you can find out these is by them having a nucleolar pattern ANA. So just important also is that the ANA must be done by an immunofluorescence as the gold standard. We've had a lot of problems with the direct ANA and the multiplex ANAs. They give frequent false positives. U1-RNP and Scleroderma 70 are some of the most common false positives. And we as rheumatologists frequently have false positive SCL70s. And this is really very harmful for the patient for an emotional standpoint, but also it gets very confusing for the doctors who don't understand it. In order to have these two antibodies really be positive, you have to have an ANA by immunofluorescence. It has to be positive. There are also false negatives, particularly with the direct ANA, because it's a bead assay and they don't have the actual antigens for the nucleolar antibodies. And since the RNA polymerase III has been a proprietary type of assay, it hasn't been included. So in many circumstances, patients will have a negative direct ANA with this assay. There are some newer scleroderma panels. They're called a LineBot panel, and they can be ordered on our MedConnect system by Quest. There's another antibody system by ARUP, but these are better than the standard multiplex assays or the bead assays under the direct ANA. But it's only if you think the patient actually has scleroderma, because it only includes the scleroderma antibodies. So the anti-centromere antibody is the long-standing RAYNAUD'S. They have a lot of bad ulcers. They have limited skin thickening. They have lots of GI problems, and I mentioned the digital ulcers. They often have small bowel constipation, rectal problems, rectal incompetence, and really some of the worst patients as far as problems, because we don't have very good treatment for motility in the GI, or those that experience all the small bowel and the constipation. There is an isolated decrease in the diffusing capacity. So even though these patients rarely have significant interstitial lung disease, they may have some fibrosis, they may have had chronic aspiration, which then can cause some fibrosis, but rarely do they have the type of progressive fibrosis that we see in our SCL70 patients. But this isolated DLCO, as I'll mention later, is the precursor for having pulmonary arterial hypertension. And so it's really important for all scleroderma patients to have PFTs and echoes on the very first time that you see them as a patient. The SCL70 or topoisomerase patient is a speckled ANA or a homogeneous ANA. Now, we often think of homogeneous ANAs as being associated with DNA or lupus, but in this circumstance, they're frequently about 30% homogeneous ANAs. And it's the classic scleroderma with really all the different types of manifestations, but only 3/4 of them will actually have diffuse cutaneous disease. A quarter of them will only have limited cutaneous disease. And that's part of the reason we've tried to get away from the Creston syndrome term, because many of these patients will have limited cutaneous disease and be called CREST, and yet they have still have a very high risk of having interstitial pulmonary fibrosis. So that's really important to remember. Even if you have someone has very minimal skin involvement, they still can have severe fibrosis. Usually it's only the diffuse cutaneous patients that will have significant kidney or renal crisis, or heart involvement. The RNA polymerase III antibody is a speckled ANA, and so if you have a patient that has an ANA that's speckled but doesn't have an SCL70, you should be thinking about polymerase III. These patients often have very early, rapidly progressive skin involvement, and even good rheumatologists miss this diagnosis, particularly since about 30% of them will not even have RAYNAUD'S at the time that the diagnosis of scleroderma is made. It is more common in Caucasians. Almost all of them have diffuse disease. Some of it's not as severe as others. They can have lung involvement, although it's less commonly severe, and most commonly it's just mild and doesn't progress. But 25% of this group will have RNA polymerase III antibody, and this is really important to make that diagnosis early. And if you don't even suspect that the patient has scleroderma, or even worse, if you suspect they have it and you think they don't have the antibody, you're likely to miss that. And that's happened several times in our hospital in the last couple of years. Some of these patients will have heart involvement as well. So there are some new associations with the RNA polymerase III antibody. One is with gastric antral vascular ectasias, or watermelon stomach, and that's a silent bleeding type of problem. It's not gross vomiting or blood or bloody diarrhea or anything. They really present with severe anemia. And the other very interesting thing is that it's associated with malignancy, and about 30% of the patients with RNA polymerase III will have a diagnosis of malignancy within the 2-year time frame before or after. And so we screen all these patients really very, very carefully for malignancies. And I have found new, mostly minor and stage 1 types of malignancy, but it's really important to look for them. And the next antibody is anti-U3-RNP, or fibrillary, and this is an ANA with a nucleolar pattern. And this is really an important one because it has a high frequency in African American patients, with greater than 50% of the African Americans with scleroderma having this antibody. They have a lot of diffuse disease. They have more muscle involvement. They have some severe GI disease. They may even have some peripheral neuropathy. Some of the GI may be a neuropathic type of process causing the motility issues. They also have pulmonary fibrosis. And then unlike our SCL70 patients, they generally can get vascular pulmonary arterial hypertension rather than pulmonary hypertension secondary to the fibrosis. So they're really complicated and very sick patients, and that contributes to the poor survival in African Americans. And I'll just give a shout out to a former resident, Duncan Moore, who is now a rheumatology fellow, former hospitalist at Georgetown, who is the first author on this paper on African Americans with scleroderma. So we, in the past 5 years, have developed, like most rheumatologists' disease, a new classification criteria, and it's a scoring system. So previously we had the definition, basically, if you had skin thickening proximal to your MCP, you had diagnosis of scleroderma. Well, that became a problem because it didn't include a lot of our limited cutaneous patients. And so now we have a scoring system that includes skin thickening, vascular lesions, capillary changes, telangiectasias, as well as organ involvement of pulmonary arterial hypertension or interstitial lung disease, as well as the autoantibodies. And so it actually is really quite easy to get a diagnosis with this weighted finding of even in the limited cutaneous patients. And in our recent study that Duncan led, of the 400 scleroderma patients, about 94% of them fulfilled the criteria with this method. So we're going to talk about the management and risk factors for different organ involvement. So hopefully when you see a patient, you'll have a feeling of how to deal with all the symptoms and problems that they have. Here we go. Okay, so RAYNAUD'S is obviously the most common and for many patients the most problematic of all their symptoms. So the first thing we do is to maximize the dose of calcium channel blockers, particularly nifedipine and amlodipine, which have the biggest effect peripherally on the fingers. We do use a lot of sildenafil now, particularly because generic sildenafil is so cheap. I had a patient get it from, I don't know, Costco using the GoodRx coupon for $18 a month, which is probably less than most patients pay for it using their insurance. If they have ulcers, it's important to use local management. We use the approach of the wound healing people, which is soaking, using antibiotic ointment and covering them. That's kind of the main approach. These are very, very painful, and I feel that pain causing more vasospasm and more pain gets back and forth. So I do use narcotics and make sure the patients are comfortable. They also can get infected, so you use oral antibiotics at least fairly freely. If you are worried about severe gangrene or really major digital ischemia and risk of having amputations or loss of fingers, we do use Doppler blood flow, arteriograms, and our plastic surgeon, which we don't have a hand surgeon right now. I use one that used to be here, Dr. John Barber, who's in Virginia. And they do both microvascular as well as digital sympathectomies and even use Botox. Not clear whether that's helpful, but hopefully it does some good. We also have a protocol working with Pulmonary to use Flolan in the pre-gangrenous state. But we're also doing a clinical trial using a prostacyclin iloprost, which hopefully will be approved next year if we can get the study done through COVID and make sure that it gets approved. So there are a lot of joint involvement in these patients, though most of the time it's mostly just arthralgias and pain in the joints because of the stiffness and the contractures that develop. So generally we use non-steroidals and low-dose steroids. We don't tend to use any high-dose steroids. We do use aggressive physical and occupational therapy, again, with analgesic, particularly in patients with early diffuse disease. If you don't get them moving and keep them moving, and sometimes you have to use some narcotic pain so they can move, because if they don't move early, they're going to lose a lot of function and really have a lot of problems later on. Occasionally, maybe again, 20% of patients might have enough inflammation, not always synovitis, but they have morning stiffness, they have improvement throughout the day, they respond to non-steroidals, they have increased inflammatory markers. So you might think that they may have enough actual synovitis or tendon inflammation that they might benefit from methotrexate or Plaquenil. And there are a few patients, I don't know, somewhere between 5 and 10% that actually have an overlap and with a positive CCP and may even actually have rheumatoid arthritis overlap. We do use TNFs. Probably more frequently, we're using anti-IL-6, tocilizumab, because of its previous studies in scleroderma with some hint of improvement in skin and lung. So we occasionally do use these other drugs. So tendon friction rubs are palpable tendon rubbing friction rubs. They feel just like you would expect a rub to feel like in a lung or anything else. And they're most commonly in the palms and the wrists, the elbows, the knees, and all around the ankle. And they really do cause a lot of discomfort for the patients and lead to a lot of the disability as far as the development of contractures. And again, it's really important to work on physical therapy and occupational therapy to get these patients moving and give them adequate analgesia, as well as if there is inflammation, some type of anti-inflammatory. The muscle involvement, there is both inflammatory as well as non-inflammatory muscle involvement, increased CPK, typical looks like myositis, proximal muscle weakness. They have positive MRIs and EMGs. It really is, some people would like to call it an overlap with myositis, but we think it's part of scleroderma. The antibodies that are most commonly associated to, of course, U1-RNP or the mixed connective tissue disease, but also the nucleolar, particularly the PMSCL, as well as the U3-RNP. And we do treat these patients like we would any other polymyositis patients, methotrexate, azathioprine, CellCept. We do use steroids. We try to avoid high-dose steroids, but generally we sometimes have to. We might use IVIG early on rather than high-dose steroids, and maybe even some rituximab. Again, physical therapy to help with strength is important. The non-inflammatory muscle disease would really only have a low level. It's much more subtle. It's not as acute, but it does lead to shoulder contractures because the patient just sort of doesn't move as much, and so doesn't raise his arms because they're weak. And so the patient does end up with fibrosis in the shoulders and have a lot of contractures. And this we've seen to be associated with the U3 and particularly in African Americans. We use low-dose prednisone and, again, aggressive physical therapy to prevent contractures and improve strength. So the gastrointestinal involvement, as I alluded to, is some of the most difficult management because we really have never had any significant motility drugs that have been approved, or I shouldn't say that. We've had some that have been approved, but they all have been pulled from the market because they have cardiac side effects. So we have lots of esophageal dysmotility, heartburn, reflux, chronic cough, chronic hoarseness, all the typical esophageal dysmotility issues. We also can have small intestinal involvement, which is it causes a lot of bloating, and sometimes with bacterial overgrowth will really interfere with function and develop malnutrition, and it's really a difficult problem. These wide mouth diverticulum are sort of interesting things, but they don't usually cause a lot of problems. So the management of esophageal particularly is with the standard proton pump inhibitors, and you get a lot of patients where their doctors have said, oh, you can't take these drugs, but you really have to have the risk balance. And in this disease, I can tell you, since I'm old enough to know before there were proton pump inhibitors, that patients had very severe contractures and more problems without that. There are some motility, obviously metoclopramide or Reglan. Domperidone is available through Canada, has less of the neurologic side effects. Erythromycin and low doses can sometimes be used for gastroparesis, but none of them are very profound. If someone has bacterial overgrowth, whether it's with just severe bloating or diarrhea, we work with our GI colleagues and try to get a diagnosis, but oftentimes we just use the therapeutic trial to see whether an antibiotic would be helpful. Now, the GI people use a lot of Xifaximine because it's not absorbed, and that's what they say they should use. It's hard for rheumatologists to get Xifaximine approved in general. I think it's also sometimes hard for the GI people as well. So I do use a lot of Flagyl and Cipro and amoxicillin. These do work, so it can be, at least a therapeutic trial to tell whether that's what you are dealing with. Octreotide can be helpful for small bowel involvement, but usually the patients are so severe that it doesn't do too much. And rarely people have to have TPN. We sometimes do use PEG tubes or J tubes, but just because it's below the stomach, it doesn't mean that it doesn't back up into the stomach. And I've actually had several people die because they inappropriately had a PEG tube that wasn't handling the small bowel. The feedings were not handled well with the small bowel. That's not exclusively in all scleroderma patients, but if they have a PEG tube in because they had such severe esophageal involvement, then it may very well be that they have severe involvement throughout the rest of the GI tract. So unfortunately, as I said, there's really nothing new in motility drugs that have been approved. There are a couple of constipation medications, Linsness and prucalopride have been helpful for that group of patients. But as far as the small bowel or the stomach or esophagus, there's some new ones in animal models, but they don't seem to be coming into the clinic. What happened here? Okay. So another problem besides the constipation is rectal incompetence, and many of these patients will describe it as diarrhea. So this is a real problem for a lot of long-standing limited scleroderma patients. So you really have to take a good history and see whether it's really not just overflow or soiling their panties and they're embarrassed to tell you exactly what it is. And then I mentioned watermelon stomach, particularly in RNA polymerase III patients, but it's also seen in late stage limited scleroderma with severe anemia and silent blood loss. And I know many of you have seen some of these patients on the floors. And that's our watermelon stomach. It looks like a watermelon, and it's not like it's all bloated. It's just that's what the gastric antral vascular ectasias look like. So pulmonary problems, as I mentioned earlier, pulmonary disease is really has been the main focus of all of our treatment efforts in the last 20 years. So some of our patients can have pleurisy or pleural effusions or pleural scarring. Actually, this is much more likely to be other causes than primary from the disease itself. Occasionally, patients will have an overlap with lupus. Some of it will be malnutrition or something like that. Or more commonly, at least in one study that I did, it was related to malignancy. Some patients have spontaneous pneumothoraces because they have bad fibrosis and bronchiectasis. Certainly aspiration pneumonia is a very common reason for hospitalization, and these patients don't have overt causes for the aspiration, and there's a lot of microaspiration that then can cause some exacerbation of their breathing, and they do respond to antibiotics in most cases, although not always. There is the increase in malignancy, all different cell types. It's not just in patients that have fibrosis. It can be these RNA polymerase III patients, or really any type of lung malignancy. Organizing pneumonia is probably less common in scleroderma, but does happen, probably more common in lupus, rheumatoid arthritis, and myositis. So the main two entities that we deal with are interstitial fibrosis and pulmonary vascular disease. And part of the role of the rheumatologists, and particularly those of us in scleroderma, is to try to identify as early as we can the risk factors for those that are going to get severe fibrosis. So most commonly it happens early in the disease, more commonly in diffuse than limited, but importantly the antibody is really the best predictor, the SCL70 and the nucleolar antibody. And as I said, all scleroderma patients need PFTs. And so if you see a decreased forced vital capacity early in the disease, or if you're monitoring these and it decreases by an equivalent of greater than 10% per year, that's indicative that these patients are going to have severe disease. Unlike in idiopathic pulmonary fibrosis, the diffusing capacity is probably not a good predictor for severe fibrosis, particularly because we see it in pulmonary vascular disease. And then many of patients will have moderate amount of fibrosis. It will stabilize, and then they get new shortness of breath. And you have to realize that this doesn't necessarily mean that it's severe fibrosis or that it's getting worse or there's more inflammation. It could be just that they have fibrosis and that they've developed something else, either a pneumonia or heart failure or atrial fib or something else may be causing the severe fibrosis. So we've been doing clinical trials in interstitial lung disease for a long time. Scleroderma lung study 1 was a placebo-controlled Cytoxan versus placebo. It was a 1-year trial followed by another year of observation. And although at 1 year there was a significant improvement between the Cytoxan and the placebo, at the end of 2 years there was no difference. Scleroderma lung study 2 showed that 2 years of mycophenolate was as effective as the 1 year of the oral Cytoxan, but it was much better tolerated. And so at this point, sort of the standard of care for early progressive interstitial lung disease is mycophenolate. So this is the new study that was actually the very first drug that was officially approved for scleroderma. It's an anti-fibrotic, nintedanib, which has been approved for idiopathic pulmonary fibrosis for about 5 years now. And they did a large, as you see, 550 person trial of scleroderma global. And they did show a significant less loss. And that's important to realize that this is all loss. And there was less loss in those that received nintedanib versus those that received placebo. But about half the patients were on background mycophenolate. And if you can see the difference here, there was a 26 milliliters loss in those on nintedanib and mycophenolate versus 58. And that was not statistically significant. And actually this 32 milliliters is about the normal loss that normal people show. And importantly, this drug unfortunately did not have any effect on any other scleroderma symptoms, or including respiratory symptoms, no improvement in their breathing, and no effect on scleroderma skin findings. And unfortunately, it has a lot of GI side effects. So although it is an option for people that have progressive disease in spite of MMF, I don't think, at least in my hands, it's going to be a first-line agent here. So these are the autoantibodies and how important they are in lung disease. So the red is the frequency of pulmonary arterial hypertension, and the yellow is severe pulmonary fibrosis. And I think this clearly shows that the antibodies have a predominance of the type of disease, particularly centromere and pulmonary hypertension and SCL70 with fibrosis. You can see the nucleolar antibodies have, particularly, this is THTO and U3, they have even more lung disease than the other groups, and it can be both fibrosis and pulmonary hypertension. Likewise, for U1, can be both fibrosis and pulmonary hypertension. And that's important because many of you will see patients with MCTD that look like lupus, and you still have to think about those patients having interstitial lung disease. So get the pulmonary function tests and monitor them periodically. The POL3, the RNA polymerase III, as you see, has much less lung disease, but they still have some. This is the pulmonary vascular disease, the severe blood vessels showing a lot of intimal proliferation and adventitial, and yet these patients classically did not have a lot of interstitial disease. Certainly when we were first studying it, we thought in these patients with what looked like classic at the time it was called primary pulmonary arterial hypertension. We thought they didn't ever have pulmonary fibrosis, but as you learn more, you find out you're not always right. So again, the risk factors for those that have high risk for pulmonary arterial hypertension: long-standing disease duration. Usually they've had RAYNAUD'S for more than 8 years. Again, mostly limited cutaneous, although there are some patients, particularly with the nucleolar antibodies, that have diffuse disease. We talked about the abnormal pulmonary function test, this low diffusing capacity, less than 55% predicted, and often it's totally isolated. They may have very normal forced vital capacities, no significant interstitial disease, but even if they have some interstitial disease, the ratio of the FVC to the DLCO is usually greater than 6, and so that's another helpful clue. The echo is an excellent screening tool, but it doesn't predict the risk of getting pulmonary hypertension. The PFTs do a much better job of that. We talked about the antibody, the centromere antibody, and the nucleolar pattern on ANA. The NT-proBNP and the BNP particularly may be helpful in patients with symptoms to see whether they have any heart involvement. But there are lots of problems with echoes in the diagnosis of pulmonary hypertension. Many echoes, they don't even give you the reading, the estimated RVSP, and in many, at least 10 to 15%, you can't estimate it because they can't get the actual tricuspid regurgitation, which is how they calculate the estimated RVSP. And echo pulmonary pressures between this 30 and 45 are often unreliable, and so we really do need to have a right heart cath, and that's the gold standard for making the diagnosis. But we also need to look at even if we don't read our actual, look at the actual echoes, we need to look what the echocardiographer says about the right heart size, how the function is, and particularly whether there's any interventricular septal flattening, which will be clues to increased pulmonary pressures. So these are the 5 groups of pulmonary hypertension that occur. The World Pulmonary Hypertension Symposium has been talking about these for many, many years now, and scleroderma really fits into all of them. Group 1 is pulmonary arterial hypertension. Group 2 is myocardial involvement, and many of our patients have diastolic dysfunction. Whether it's from scleroderma or not is very difficult to tell. Some of our patients have systolic dysfunction as well, but certainly we see patients with group 2 pulmonary hypertension. Group 3 is interstitial lung disease, and many of our patients have enough interstitial disease, severe enough that they have hypoxia, and then that can develop significant secondary pulmonary hypertension from interstitial disease. Group 4, or thromboembolic disease, chronic thromboembolic disease, is not very common in scleroderma. It can happen more commonly in lupus and more generally associated with antiphospholipid disease. There's another type, which is in group 1 prime, which is pulmonary veno-occlusive disease, which is seen in scleroderma more commonly than in idiopathic pulmonary arterial hypertension because there's more venal involvement, and these patients have severe hypoxia and they do not respond well to the vasodilators treatment. So this was the story of what the outcome for patients with pulmonary arterial hypertension was years ago. Before we had any treatment, basically they all died with a 2 or 3 year survival of 30%. And this is the survival with now, this is from my multi-center PHAROS trial, which is an observation cohort that we followed patients up to 10 years with pulmonary arterial hypertension. And importantly, the 5-year survival, as you saw, was 0 before, is now up to 76% for specifically for pulmonary arterial hypertension survival. All-cause survival was lower because people died of scleroderma, they died of cancer, they died of infections. But that's really, we've really made a major difference in changing this disease from almost a death sentence to a chronic, a difficult, but still chronic disease. And that's because we now have 14 different drugs that can be so 14 different drugs that can be used in all forms of pulmonary arterial hypertension, including associated ones like scleroderma. And there are 3 different pathways at the moment. The endothelin pathway, there are all 3 oral agents. There's the nitric oxide pathway, most commonly the PDE5s. There's also another drug that's a soluble guanylate cyclase stimulator. And then the prostacyclin pathways, which range from IV to subcutaneous to inhaled to oral agents. There are now 2 oral agents that are approved. Difficult to manage as far as side effects, but least potentially a possible treatment for our patients. So heart involvement is very common on any type of test that you do, whether it's an echo or a EKG or a thallium or an MRI, but clinically it's fortunately is not nearly as common or is nearly as much of a problem. Overall, severe heart involvement, it was independent of pulmonary hypertension, was only seen in 7% of limited and 16% of diffuse. A lot of pericarditis, but there's also a lot of pericardial effusions that aren't clinically significant. Cardiomyopathies, the most common and diffuse, and then arrhythmias requiring treatment are also quite common. So renal crisis is used to be the most feared condition, and now we have had good treatment for it for a long time. And I'm sure many of you have seen some of our patients that have been in the hospital. These patients often have severely increased blood pressures. Their creatinine rate increases daily. Even after the blood pressure is controlled, they may have a little bit of proteinuria or hematuria, but it's not a primary glomerular process. They frequently have microangiopathic hemolytic anemia with thrombocytopenia, and this MAHA is actually seen in about 50% of the patients. It's also associated because of the malignant hypertension with heart failure, and pericardial effusions are common. Again, the predictive factors are early diffuse scleroderma, rapidly progressive skin involvement, heart, pericardial effusions. And when I actually first did this study years ago, before we knew that we had this RNA polymerase III antibody, and later when that was discovered, this was the reason why they had early rapidly progressive skin involvement. We also showed that high dose steroids greater than 15 milligrams of prednisone does precipitate renal crisis, although we really don't quite understand why. But not having increased blood pressure or having abnormal renal abnormalities really, it doesn't predict it in the future. It might be predicting it happening right now, but not months and months in the future. So again, this is a study from a while ago now, but it was the first 145 patients treated with ACE inhibitors at the University of Pittsburgh. And you can see that more than half of these patients had a good outcome. Many of them still did not have a good outcome. Many of them died within 6 months, and many of them required permanent dialysis. But it is important to note that if you look at those that required some dialysis, more than half of them were able to discontinue dialysis and not have to go back on it. So ACE inhibitors have really dramatically improved renal crisis, particularly if they started early, controlling the blood pressure in 3 days, and start before the creatinine is greater than 3. those are sort of the guidelines. Unfortunately, over the 10-year period from the time I wrote that paper until France and England did a similar study, we really didn't improve the outcomes much more. Everybody had pretty much done the same, had the same outcomes. But if you come off of dialysis, most patients stay off dialysis, and only 6% of that group later had to go on to dialysis, and most of those were because they had stopped their ACE inhibitor. The survival of the non-dialysis patients, meaning the ones that came off and ones who never needed it, was just as good as all the other scleroderma patients that didn't have renal crisis. So that's all good to hear. So we still don't have treatment for the overall scleroderma for skin involvement. This was my first mentor, Dr. Gerald Rodnan, and it really, some of them are still available, like just about anything, and zero therapy, you wouldn't believe, and so on. We keep trying. Over the last 10 years, I've had probably 10 different trials that we've done in scleroderma trying to find a drug. And really the only thing that has been clearly shown to really dramatically improve skin involvement and probably improve overall outcomes is the stem cell transplant. And there have been 3 studies. This is a small 1-year study in a single site. This is the European study, ASTIS, and the Scott trial. The European study had a good bit of early mortality from the treatment. The way the Scott trial did it, they had improved overall survivals and less treatment-related survivals. These last 2 studies compared it to IV Cytoxan, and the survival was clearly better using stem cell. But it's a big procedure, and there is clearly some risk, and it's hard to know who is the best type of patient to respond to this treatment. So the management of this diffuse skin thickening at this point is, again, we've talked about the aggressive physical and occupational therapy. If you have someone that has skin, tendon, joint, muscle involvement without a lot of lung involvement, we'll use high-dose methotrexate, at least I do. If you have anybody that has a hint of lung involvement or at risk for lung involvement, we'll use primarily mycophenolate, maybe some Cytoxan. And again, we're still doing a lot of clinical trials because we still are trying. So in summary, it is a challenging disease. There's a wide range of manifestations, but we can treat many aspects of the disease. There's been major progress with the life-threatening complications, including renal crisis, pulmonary arterial hypertension, and interstitial lung disease, but we still have very many unmet needs, particularly the skin, RAYNAUD'S, GI, and calcinosis. So I hope this will be helpful for you to have a better picture of what scleroderma is, and